Well, welcome everyone. I'm Dr. Allison Kelly Hedgepath, and I'm here with my colleague, Dara Lee Lewis. And we want to welcome everyone to our monthly webinar series. And we are thrilled today to have all of you join with us and welcome Dr. Karen Lee, who's colleague and good friend, and for my patients in the audience may also be your sleep doctor, because she sees a number of our Lown group patients, and she's going to be talking about how to improve your sleep. So a topic that I think everyone is really interested in. So Karen, thank you for joining us.
Great. Very nice to meet you all, and hope that everyone can learn a bit from today. Wonderful. Okay, so I think everyone can learn a bit about sleep. So just a little background about myself, some context is I am a neurologist and also a sleep specialist, and I practice adult and pediatric sleep medicine. So I know about both, the whole age span of sleep, basically. It's a little unique. I work within the Mass Eye and Ear Otolaryngology department, and it confuses a lot of people because I'm not actually an ENT. But since sleep has so much to do with the airway, that's why I'm part of that group. So it's a little unique. I also see patients for facial pain, headaches, and all that because it is also very intertwined with sleep. So, okay. So a little about sleep. Despite sleep being about a third of our lifetime, actually, we all personally know someone or are touched by issues with sleep. I think everyone can agree with that. And these are little basics of what I'm going to be talking about today. So I'm going to be talking about the fundamentals of sleep, some recommendations about sleep duration, the basics of insomnia treatments, medications, and or cognitive behavioral therapy for insomnia. We'll be discussing that a lot. It's called CBTI. Techniques to improve sleep, consumer sleep technologies, like wearables, nearables, apps. I think some of you have questions about that. Cannabis and sleep. Hot topic. And when is a sleep consultation actually appropriate? So some essentials of sleep. I won't focus, we have a lot to get through today, so I just want to focus on one part of this slide that's especially interesting to a lot of people. Is there's this emerging field that we're really starting to understand more in sleep, about sleep being very important to remove waste, neurotoxic waste that builds up in our brains. So even if you have good sleep quality, if you have sleep deprivation or you're not getting enough sleep, and sleep disorders cause insufficient sleep and poor quality of sleep, we are unable to filter out toxins that build up in our brain. There is a special system called the glymphatic system for removal of actual beta amyloid. And beta amyloid is one of the compositions of the plaques and tangles that we see built up in the brain of patients with dementia, specifically Alzheimer's disease, right? So this has been a really hot topic, and a lot of the neurobehavioralists or dementia specialists will send patients to me regularly for this because unfortunately still out there in the world of dementia, there's not many groundbreaking treatments. So we really try to do the best we can do to control what we can. And something very important in that is sleep, making sure we protect a quality and quantity of sleep that I'm going to get into. So the relationship between sleep and dementia is pretty concerning that we can take some control over. Just some basics of sleep, because a lot of terms are thrown around. I see a lot of patients, confusing different terms with actual terminology. So let's talk about that. There is light sleep, there's deep sleep, and there's dream sleep. Okay, so let's split all this up. So there's also these terms you've all heard, non-REM and REM. REM stands for rapid eye movement sleep, which is our dream sleep. Okay, because in rapid eye movement dream sleep, everything in our body is paralyzed, all of our muscles except for our diaphragm. Okay, our eyes are moving like rattlesnakes, rapid eye movement, and we can see this all in sleep studies. Okay, and that's typically when we dream. So stage 1 and stage 2 sleep, just so you all know, when I interpret sleep studies and we look at the brain waves, that's defined as light sleep, which is N1 and N2. Stage 3 is deep sleep. It's also called slow wave sleep, SWS. Okay, that's part of non-REM sleep. Okay, and then there's REM sleep, which is dream sleep. Okay, I notice a lot of individuals will come to me being concerned about their deep sleep or their dream sleep, or they think it's the same thing and it's different. And really the long and the short is that all the different sleep stages are important that we get. We cycle through them throughout the night and they all have different reasons of importance. For example, we see spindles, which is really important in our light sleep for memory consolidation and forming memories. And there's actually studies for years being done now on acoustic modulation of our sleep, where there's different sounds that are at certain frequencies that we can listen to in our sleep to help cognitively. We look at these in dementia patients actually, but we are thinking of cognitive enhancement for all individuals. Imagine if you could go to sleep and you could wake up smarter just by certain acoustic modulations, for example. So I don't want everyone to get lost in when they come to me, they're just so worried about their deep sleep or their dream sleep, that all of these stages in a healthy fashion in the correct order and correct amount are important. This is just a sample of what we call a hypnogram. Okay, so hypnogram is looking at the different brainwave data on the studies when you come into the lab over at night, not a home sleep study. And it's showing the different sleep stages that you have, okay? That the gold standard for accuracy for this is an in-lab study. So on the left side, everything at the level up here is wake. R is for REM sleep, dream sleep. N1 and N2, everything there is light sleep, and N3 is deep sleep. So what happens, interestingly, is throughout the night, we go through different non-REM and REM cycles. Non-REM and REM cycles throughout the night. Normal, healthy individuals, about 4 to 5 a night. So we start awake and then we drift into lighter sleep, deeper sleep. And then you see we go to lighter sleep and then we dream. Maybe we wake up, go back into our deeper sleep and then wake up, back into our deeper sleep, wake up. So you can see this pattern happens over and over in a healthy manner throughout the night. Most of our N3 deep sleep happens in the first part of the night. And the second part of the night is where we see most of our dream sleep. The last third of the night is where we have most of our dream sleep. And the dream sleep periods, as you can see here, nicely elongate in duration throughout the night. Okay. And it's healthy and normal to awaken throughout the night. We may or may not perceive those, but we don't want this hypnogram to deviate too significantly. Here's an example of someone with obstructive sleep apnea. Most of you have heard of. This is the most common sleep disorder I'd see, probably besides insomnia. And I have little arrows with marks to kind of show you the levels to make it easier because it's hard to see here. So blue is this individual's awake and then they have light sleep and they're going in and out. They can't sustain their sleep. They keep waking up and they're getting to another stage of light sleep. And then finally they get to some deep sleep here much later in the night and they're trying and they just can't dream. They just can't get to dream sleep. They keep choking themselves with apneas, out of sleep, and fragmenting their sleep. So you can see how bad this hypnogram looks compared to this hypnogram, right? And that's just an example of sleep apnea. But we can see all types of hypnograms be disturbed for different types of sleep disorders. So when we talk about sleep, so many people tend to focus on the quality. But something that's very important that I want everyone to walk away understanding is the quantity is almost equally as important. And that's often something that's modifiable by our behaviors. And it starts with an understanding of the quantity of sleep that we all need. So the big question is, how much sleep do you think we need for optimal health? Well, what does the data show on sleep duration? Interestingly, when I was training over 10 years ago in fellowship, what we would say is, maybe you need as much sleep as you feel you need. What does it feel like, etc. Gone are those days. We needed actual strong data on this. So in 2015, there were consensus statements made by all the big governing sleep bodies. The biggest one that we go by is the AASM. Which I'll kind of quote throughout this presentation. They stand for the American Academy of Sleep Medicine. There's also the Sleep Research Society. There's ATS, the American Thoracic Society, and then the National Sleep Foundation, NSF. Okay, and what they did to develop these guidelines is they looked at 9 categories. How does quantity of sleep affect general health, cardiovascular health, metabolic health, mental health, immunologic health, human performance, cancer, pain, and mortality? I have an entire presentation on all of this. There's so much I could talk about all the different papers and findings they had, which is not the purpose of today's talk. But the findings were really interesting in the different categories. The conclusions are what I want to focus on now. And the main conclusions are the sleep needs vary significantly by our ages. And children require a special attention to sleep for their maturational processes. And if you have children out there or younger children, it's important to know about this. Anywhere less than 6 to 7 hours of sleep per 24-hour period is associated with adverse health outcomes. And that includes weight gain, obesity, diabetes, hypertension, heart disease, stroke, depression, impaired immune function, increased pain, impaired performance, increased errors, greater risk of accidents, and increased death. Just reading all those off to you individually, because it's important to understand how far-reaching the issues of sleep are. And that's skimming the surface. There are so many other diseases associated with sleep. Interestingly, the study showed greater than 9 to 10 hours in a 24-hour period may actually be associated with adverse health outcomes. So too little or too much time in bed sleeping can lead to health outcomes that are negative. So what's recommended overall is that adults sleep a duration of 7 to 9 hours is the magic window in healthy individuals. There's some variability exists. I mean, if you're a patient recovering from stroke or you have cancer, you have multiple sclerosis, there was a time in your life with stress, you were taking care of a sick loved one. I mean, this can vary, but it's important to know the recommended duration average in healthy individuals. Also, the conclusions was drowsy driving is a very important cause of motor vehicle accidents and death. Occupational demands are frequent causes of insufficient sleep and can lead to accidents in the workplace. Sleep disorders are common and they can cause significant morbidity and death, and they have substantial economic impact, but important, they're treatable. Many people with sleep disorders remain undiagnosed and untreated still. Okay. In fact, most patients, not most, a good amount of patients that see me don't even know that there is a sleep specialist that they can see to talk in more detail about this stuff with. So this is the magic chart that I like to show my patients. I think it's very powerful. The brown here, this is what matters for what's recommended for the hours and at different ages. So I probably don't have that many youngsters in this age on this presentation. But if you think back even to yourself, the amount of hours you were getting in your school age or teenage years, or if you have any children at these ages, people are definitely undersleeping. I was. And what's important that I focus on with my patients is age 18 to 64, really should be focusing on 7 to 9 hours of good quality sleep. Because we're just talking about duration, but that duration should be good quality. And then once you are 65 or older, that shaves off just a little. The 7 is the same, but 7 to 8 rather than 7 to 9. So how common is insomnia? Let's talk a little about insomnia. Well, what's the definition of insomnia? First of all, you don't need a sleep study. You should not use a sleep study to diagnose insomnia. Insomnia is a clinical diagnosis. So meaning I interview you, we discuss, and it's very obvious, and I can diagnose if you have insomnia or not. It's defined as difficulty falling asleep, staying asleep, waking up too early with inability to return back to sleep, or feeling unrefreshed by your sleep. The National Sleep Foundation, the NSF, which has a lot of data for patients, especially if you want to read about education about sleep. Some important data they've shared is that NIH estimates about 1/3 of the general population complains of sleep disruption, and about 10% have associated symptoms of daytime functional impairments. That's consistent with the diagnosis of insomnia. Those are really high numbers. In 2005, a poll showed that greater than half of people reported at least one symptom of insomnia at least 5 nights per week within the past year. And about 1/3 reported at least one of these symptoms every night or almost every night in the past year. So if you've ever had, I'm sure most of you have had insomnia symptoms. If so, you're not alone. 2 of the most common symptoms experienced at least a few nights a week in the past were waking up feeling unrefreshed or waking up a lot during the night. Another poll in 2003 showed there was a little bias towards women. I do see that in my clinic with insomnia. So this poll showed 63% of women compared to 54% of men experience insomnia symptoms at least a few nights per week. So how do you treat insomnia? Very straightforward, as in the different options. So there's medications, hypnotics, sleep aids, those are the different terms for them. Then there is the gold standard of treatment for insomnia, and that's cognitive behavioral therapy for insomnia, CBTI. Now, this is presuming your insomnia is not because of a different sleep disorder. When I see my patients for the first time, if they do have insomnia, I do a detailed interview and intake to ensure that their insomnia is not from some other disease, such as sleep apnea or a parasomnia disorder or restless leg syndrome or some other sort of disease that's disturbing their sleep. Insomnia that's not caused by another sleep disorder or not another medical issue is called psychophysiological insomnia. And that is what we treat with CBTI as the first line. And I'm going to talk a little about CBTI. It's different than sleep hygiene. And then another option for treatment is combination therapy. So that's medications and CBTI combined. So I want everyone to understand that sleep hygiene is not the exact same thing as CBTI. So sleep hygiene is defined as a series of healthy sleep habits that can improve your ability to stay asleep and fall asleep. Okay. If treating insomnia was as easy as sleep hygiene, we wouldn't have long lines out the door to get into the sleep clinic. It's much more than just giving someone a list of instructions that you can learn, try to apply online. Okay. Cognitive behavioral therapy is one-on-one therapy. Okay. You see it with a board certified, trained insomnia psychologist. We call them CBTI specialists, and they help address your thoughts and your behaviors that are preventing you from sleeping well. Okay. They engage in sleep diaries with you, ways to track your sleep, and then do education. And they talk about your sleep and how they would individualize improving your sleep. And I'll talk a little more about CBTI, the components later. The difference, again, CBTI is not seeing a therapist, talking about your life and past, although that could contribute to insomnia. They are not focusing on PTSD, depression, anxiety. They are just focusing on your insomnia and how to improve that. And that's all they typically do in their practice. So what are the components? These are main components of CBTI. So one of the first things is sleep restriction. There's a gentler form of it called sleep compression. So an example of sleep restriction is someone that tells me that they get in bed at 10 p.m. every night. They get out of bed at 7 a.m. every morning. And 100% of the time, for example, they're unable to fall asleep for 2 hours. Even though they get in bed at 10, they know they won't fall asleep ever before midnight. So a temporary technique we use, if we use sleep restriction over sleep compression, is we'd say, okay, you're not allowed to get into bed until 12:30 every night. Get out of bed at 7 a.m., but you can't get into bed at 12:30. So we're cutting out that time that they lay there awake anyways. And then we're putting them to sleep later than they normally would get in bed. And we increase their drive and their body's homeostatic need to sleep, so that the time they spent in bed is more efficient, where they're sleeping more of that time. That technique works pretty fast, but under the guidance of a CBTI specialist, you guys choose the times for bedtime, rise time, and then slowly decompress or unrestrict that sleep schedule over time. You can't get in bed until 12:30. Then you can't get in bed until 12:15 and until midnight, depending on what your goal is and your response at every follow-up to that. Okay. Then there's stimulus control therapy. And that's just focusing on different behaviors that stimulate being awake in bed and having insomnia versus actually making you feel sleepy and sleeping well in bed. Okay. There's cognitive therapy, which is really important. It's addressing the dysfunctional thoughts and beliefs around sleep. Like a common one is, if you start having trouble with insomnia, people will tend to catastrophize about sleep and think in bed, right? I mean, if this has ever happened to you and you'll start thinking, well, how is this going to affect me? What should I take? This is going to affect my next day. Should I make an appointment, or I have to talk to my doctor about this? What pill should I take? Right? And just on and on and on. And it can really get out of control. The CBTI specialists talk about relaxation training. There's all different techniques for this, with different success with different patients. Some people do well with guided meditation. Some people do well with audiobooks. Some people do well with breathing exercises. You work with the CBTI specialist one-on-one to figure out that perfect recipe for you that's beneficial. Then there's circadian rhythm and treatment. The timing of your sleep is incredibly important, actually, to have the right sleep drive and be sleepy at the right time, cued at a similar time each day, and feel awake when you should feel awake. Okay, so this gets reinforced, and we use input from light and your body's circadian rhythm to understand what that rhythm should be. So the CBTI specialist helps with that. And then cognitive behavior therapy. So it's a combination of above, the behaviors and the cognitive thought processes to change your sleep. So much more than just talking to someone about sleep hygiene, which is what often prevents people from going to a CBTI specialist. I would say the biggest barrier to seeing a CBTI specialist, though, actually is not being told about it. A lot of non-sleep specialists are not even aware of CBTI specialists. The other barrier is cost and availability. So before, the biggest issue was cost, just like therapists. A lot of them are only taking cash pay, but we do have a lot that do take insurance. The other issue is access. Since the pandemic, especially, just like it's very hard to find therapists, it can be very hard to find a CBTI specialist that has availability. The good news is most of them are doing telemedicine appointments these days since the pandemic. So you can tend to find one, especially if you're cash pay, you could definitely find someone and you can have your follow-ups at a much faster rate with CBTI. So what's interesting, I want to go over this chart, is let's talk about how effective CBTI is compared to medications for sleep. So this is a study that looked at changes in wake after sleep onset. We call that WASOs in the sleep world, WASOs, measured by sleep diaries. Okay, so I want to acquaint you with this chart. So CBT right here stands for cognitive behavioral therapy treatments. PCT is pharmacotherapy, so that's pills, sleep aids. Then this is combined therapy of CBT and PCT, and this is placebo, where nothing was done. So look at this y-axis is how long it's taking people to fall asleep. So pre-treatment, this dark black bar, people are taking a long time to fall asleep. So then the post-treatment is the first one here. Look at CBT, how much shorter after treatment it took them to fall asleep compared to pills, compared to combination therapy, not too bad at that time point. And then, I mean, placebo, nothing's being done. Then 3 months, look at CBTI, how it's helping. Oh, and there we see the medications start wearing off, which is a problem with the medication. People start developing habituation, getting used to the medication, they're wearing off, or having side effects from the medication. Then look at 12 months. Look, CBT is still effective. Pharmacotherapy is really not effective. And the combination therapy, okay, but not as good as CBT alone. And then you look at the 24 months and the outcomes are much more staggering, right? Compared to here and here. So just this box shows that in the short and long term, CBTI is more effective than both medications to help you with insomnia and combination therapy of both. So it's always felt to be the gold standard of treatment once other sleep disorders or other medical issues like thyroid issues or something are ruled out as a cause for your insomnia. Okay, let's talk about how does chronic insomnia develop? Well, I can usually figure out this model within most of my patients. So Spielman developed the Spielman's 3 Ps of insomnia, which I often counsel my patients on. So parts of this we can't control and parts of it we can. So let's start with people have predisposing their biology or DNA, right? So in the beginning, someone is just predisposed. You are the individual that if you're stressed, it can affect your sleep, or you're the individual that it doesn't affect your sleep. You can't control that, okay? Then something happens. There's a divorce I see, there's a death in the family, there's stress with children or the parents, or someone's health has issues, something with work, right? And that's the precipitating factor here. And then we develop some bad habits, some perpetuating factors. Things like napping because you can't sleep at night. Now you're tired during the day. You're affecting your sleep drive at night. You're spending more and more time in bed trying to sleep. And you're developing a ton of poor habits unintentionally because of the insomnia that was triggered by these precipitating factors. And then you get to the chronic insomnia, where these factors are just really taking over despite this precipitating factor going away or improving significantly. That's how we get in this chronic insomnia zone. So what's important to know is this: the perpetuating factors, that is what is modifiable and very treatable. And that is what CBTI focuses on right here. Okay, we can't change any of these. Let's talk about melatonin, because that's a hot topic. So a lot of you may, if I was in front of an audience, I'd ask how many people have tried melatonin, take melatonin, raise of hands. A lot of people, most people have at least tried it at some point in their life, especially if they're coming to my clinic. So what you may not know is the data on melatonin. So all the sleep specialists and the insomnia specialists have known for years that melatonin is not effective as a sleep aid. Not effective in the studies as a sleep aid, okay? What it's very effective for is treating circadian rhythm disorders. So if someone has jet lag or we need to change their biological clock. So one of the most common sleep disorders is that this is helpful for is delayed sleep phase syndrome, DSPS, where people have a preponderance or a proclivity to want to go to sleep later, which starts, by the way, in your teenage years when you go through adolescence. So someone that can only, they go to sleep at 3 a.m. and they wake up at 11 a.m. regularly. We can use melatonin very effectively. Usually it's at physiological doses less than 1 milligram, like 0.5 milligrams. And you give it anywhere from 3 to 6.5 hours before bedtime. And it's not used to make an individual sleepy per se, it's to reset their clock appropriately. And you give it for a temporary time as you pull their clock forward. And then once their clock is aligned, you don't just keep taking it, pulling their clock forward, then you stop administering the melatonin. What's happening out there in the real world is patients feel that it's safe, unfortunately, to take anything that's over the counter, right? And what happens with doctors is, and even me, if you're reaching for melatonin versus Ambien or something prescription, that's much more habit forming. A lot of doctors will allow or recommend their patients to take melatonin because it's preferable to something else. But it's important to know that the studies do not show that it is effective. Melatonin is released in all of our brains. It's released and helps us transition into sleep naturally. Blue light into our retina is what suppresses the release of melatonin in each of our brains. Melatonin is released by the pineal gland. So what's important to know, though, and a lot of information has been coming out more lately about this, is brands of melatonin and to control the quality of melatonin that you get when you go to the store and try to buy it. So there was a big journal article from the Journal of Clinical Sleep Medicine, which is one of the most seminal journals in the sleep world, in 2017. And what they did is they looked at 37 different melatonin supplements like Natrol, these different brands. And they looked at how much the content varies, which was a whopping negative 83% to 478% compared to the labeled content, and the worst in chewable, which is, by the way, what children usually take, okay? And then the lot-to-lot variability within the same product was 465%. So really frightening quality control of what you're purchasing over the counter of melatonin. Also worrisome, 26% of them had 5-HT, which is serotonin, which was not even on the label for these melatonin supplements. So it's very hard to control what's out there. So then you ask, well, why doesn't the doctor just prescribe? We can prescribe melatonin. The issue of why we typically don't prescribe it is usually a cost issue, because just like iron, a lot of the time, if you purchase it over the counter, it's a lot cheaper, but through insurance, it's not covered. It can be a lot more expensive. Then recently, with the pandemic and such a surge in sleep disturbances in both adults and children, and if you have children, I mean, the children or your grandchildren were not able to go to school, not get their physical activities in, right? The sleep was just all over the place. There was a huge jump in pediatric usage of melatonin. The annual pediatric ingestion rate is 8,000 in 2012 compared to 52,000 in 2021, a 530% increase. And what the emergency rooms were seeing, 15% of overdoses needed to be hospitalized. So what we're just seeing is this huge surge in the use of melatonin expressed in what we saw in the emergency room in hospitals. I mean, the question is, why is there an overdose or too much of melatonin? Sometimes maybe children getting their hands on melatonin in the house. Other times, I can't tell you how much I talk to teenagers, the pediatric population taking it on their own, melatonin with no regulation. I mean, people will be telling me they're taking 20 milligrams or 15 milligrams sometimes. I mean, from a sleep aid perspective, if someone's going to take it, you really don't want to be taking more than 5 milligrams, maybe 3 milligrams, 2 milligrams. You get into the territory of causing more side effects like morning grogginess, hangover, feeling tired during the day, confusion. So what can be done to improve your sleep habits? I'm just trying to keep my eye on the time. So winding down. So if you're an individual with insomnia, so for example, I am not, I can be on call, run around the hospital, come home, argue with my husband, get in bed, turn off lights to go to sleep. Because I, knock on wood, don't have insomnia at this time of my life. Now, if you do have insomnia, it's not that easy. You can't just shut the lights off and tell your brain to just go to sleep, right? So people with difficulty falling asleep or staying asleep, we discussed that everyone needs a transition period called the buffer zone. So the buffer zone allows you to transition into sleep and not just expect it like the lights out, okay? Anywhere from 30 to 60 minutes, it's a routine part of your day. You start dimming the lights in your room or in your house, whatever your setup is, if you have others there. You can choose, what is that for you? 30 minutes, 60 minutes, how much does it take for you to wind down? You do something relaxing during that time. You're not allowed to engage in any stressful activities, no emailing people from work, arguing with your children or your spouse, talking on the phone, watching a riveting crime series or something on TV. You really want to be relaxing and trying to avoid electronics, actually, because they emit blue light, which can suppress your release of melatonin in your brain to help you drift into sleep naturally. There are blue blocking glasses out there for some people as well, but this is just really protected wind down time that almost all my patients really appreciate and enjoy if you can put that into your schedule. But beware of binging. So I am, and I think so many of you out there are guilty of that. So this was some interesting information from the American Academy of Sleep Medicine. They asked adults to vote, what are the most important things in your life? Family, number 1. 2, sleep. 3, work. 4, nutrition. 5, exercise. 6, entertainment. Okay. But this is the percentage of US adults who lost sleep from staying up for watching multiple TV episodes or streaming services, 88%. That's what I usually see the most with my patients. Finishing a book, 66%, sports, 60%, video games, especially, for kiddos, 50%, right? So what we put at importance is not translating into what's happening into our daily activity. I'm sure that can resonate with a lot of you out there. This is, a bad habit, behavioral issue that is, by the way, modifiable. And I speak to my patients about techniques that can improve that, such as setting alarms at night, etc. So let's talk about conditioned responses. So you all remember maybe Pavlov's dog, right? Where there's an unconditioned stimulus, just some rewind, some food makes the dog salivate. Now you replace the food with a neutral stimulus like a bell. The bell, there is no salivation with the bell. But if you combine the bell with food, then there's this response of salivating. And then you use the bell and ultimately the dog will salivate. Well, the idea of this for stimulation therapy is we want activities with the bed to stimulate sleep. We don't want it to stimulate being awake. So i.e., you don't want to be in bed on your computer talking, associating awake activities or just negative activities that don't have to do with sleep in bed, such as laying in bed, torturing yourself, trying to sleep. You don't want the bed to make you think that when your bed hits the pillow. Okay, you want it to be automatic, and it's just a passive process. You get in bed and your body conjures up feelings of sleep. Okay, so our basic rule is the bed should only be used for sleep and sex, and that's it, and that's the only association. And you want to establish a regular pre-bedtime and a regular sleep wake schedule, which we'll get more into. So stimulus control is, like I said, you want your bed to conjure up sleepy thoughts. So you want to get in bed when you're drowsy. You don't want to force yourself Like the individual I said as an example, you know you're not going to even feel sleepy till midnight, but you just get yourself in bed at 10 p.m. knowing very well every night you're not going to sleep anyways. That actually makes things worse, and it reinforces this negative relationship with your bed and trying to sleep at night. One of the biggest mistakes that individuals make is clock watching. You don't want any clock watching if you're struggling with insomnia. If you have an alarm set, there's no reason to ever look at the clock. All the clock does is stimulate a thought in your head or make you more awake or make you more worried. And so if my patient is able to tell me the exact times because I can tell they're looking at the clock, that's a problem. Now, something else that's important is if you're in bed and you're unable to fall asleep for about 20 minutes, again, don't look at the clock, you can estimate about 20 minutes, you really want to remove yourself from that situation, okay, in that bed. Get up, go to another space, another room in your home if you have the room. I was working in New York City before. A lot of people don't have that room. You can have a separate chair or something in your bedroom, you want to remove yourself from that sleepy bed environment, right? And do something boring and relaxing until you're drowsy, and then you can go back to your bed and sleep. And once you feel sleepy, go to that bed. So remember, you're entering the bed when you feel sleepy. That's the relationship with the bed. Sometimes patients will have to do this more than once a night, okay? Understand, this is important, that lying in bed awake will create an unhealthy conditioned association between your sleeping environment and being awake, okay? And you need to break that. That's what the CBTI specialist helps you break as well. So what are activities one can do? It's such a myriad and different activities that my different patients do. A lot of patients will read a magazine that's boring, or a book, something without blue light being emitted into their eyes. So you can knit, you can fold clothes, you can clean. A lot of my patients will listen to a podcast that's not too engaging, relaxing music, whatever your choice is. A lot of people do have benefits with guided meditations, mindfulness guided meditations. When I used to work at UCLA, they had a department that focused on this. And here's a nice free website where you can just download these different podcasts of guided meditations that can help you, ease back into sleep and feel drowsy. Let's talk about a worry book. It sounds silly, but we have a lot of success with individuals. So if you've ever had insomnia at all, you may be in bed on a loop or thinking about different things you have to do, or for work, or your grocery list, or something for your child, or appointments you have to make tomorrow, etc. And you're just perseverating about thoughts that won't shut down and will not allow you to transition passively or naturally into sleep. Well, a worry book is really helpful for a lot of individuals. You keep it on your nightstand. If these thoughts just won't shut down, take out that book and get all those thoughts down. Get them out so that they're no longer circling around your head, and you can go back to sleep. You may have to pick up the worry book more than once if other thoughts come up and you're anxious about that, but just get all of that physically out, and it can be very cathartic and helpful, decrease anxiety and help you get to bed, okay? Something as simple as that. Substances can very much affect our sleep. So caffeine tends to have a shorter half-life, but if you're having trouble with sleep, we really try to make it a rule of thumb to avoid afternoon. Alcohol, I'm going to have a separate slide to talk about how that affects your sleep, because a lot of individuals use that to improve their sleep, which is counterintuitive because it affects your sleep. Nicotine, of course, can be stimulating, and heavy meals can be an issue with your sleep. In the autonomic nervous system, which is a part of our body that automatically helps us do things like breathe, our heartbeat, etc., that we don't make the effort to do. Sleep is a parasympathetic process versus a sympathetic process. So our body is trying to work parasympathetically to help us sleep. If you eat and you need to digest, digestion is a parasympathetic process. So your digestion is going to be beating your body's ability to try to work on sleep, and it's going to focus on digesting. I'm sure you've all experienced the issues with heavy meals too close to bedtime and how that can affect your sleep. So how does alcohol specifically affect your sleep? Well, interestingly, alcohol, and I'm not at all recommending you do this, but if alcohol was infused intravenously throughout the whole night of sleep, it would work wonderfully to help you sleep. The issue with alcohol is that it has a very short half-life. It bounces and rebounds out of your system really fast. So it's tricky. Although it can help you in the beginning of the night fall asleep faster, it definitely fragments your sleep when it's out of your system later on in the night. And that's the big issue with it affecting your quality and chopping up your sleep. And I'm sure many of you experience that. So through the years, I've seen a lot of individuals that have kind of just realized this on their own, looking at patterns, will have to they shouldn't, but they will take shots of alcohol, throughout the night to keep them asleep because of that very issue, which of course, again, I don't recommend, but it kind of shows you about alcohol. So a sleep promoting environment is very key. I actually can't tell you how many patients tell me, they invested and changed their bed or changed their pillows or changed their sheets, spoke to their partner and they agreed on XYZ, and it really did make a dramatic difference. I'm not saying it treats all sleep disorders, but it can actually make a big difference. And a lot of individuals will complain to me about things in their room that are modifiable, right? In the summer, or when the sun comes out early or something like that. There's a lot that can be done. Blackout curtains can go a long way. Eye shades, if that, something bothers your partner, right? I don't promote any specific smart beds or products. People ask me a lot, but finding one that's suitable and comfortable for you and your partner can be a very nice investment. Sound machines, if people live somewhere noisy or they don't like it, a certain sound in the background, etc., that can just help be a constant nice sound in the background. Temperature, we're going to talk about, is really important. And one of the biggest issues I hear disturbing sleep is pets, actually. I interview every patient who's in the bed with you, it's their pets and all that stuff. That is actually interferes with people with their sleep a lot, and that has to be worked on sometimes. The kids is the big issue. I don't think you can make your kids go away. That's a common one. Or the baby crying, or the kids come in your room, etc. But when the kids get older, there can be a negotiation with them and your partner. I see partners causing a lot of different issues too, misaligned schedules, etc. There's sometimes I need to have families, have a meeting to discuss this, to protect an individual's sleep time, if that's possible within a family. So let's talk about temperature. Temperature matters. You may notice you're not able to sleep when you're really hot. Well, that's because the core body temperature actually needs to drop for us to drift into sleep. We've all had those nights when we're hot, tossing and turning. That's biological. Okay. So we do need to keep the room somehow and keep yourself from not being too hot. Sometimes that's a battle between your spouse, and you guys need to figure that out, but that's important. You're not going to be able to sleep without that being controlled. There's a physiological reason for that. Exercise. So exercise is wonderful, besides for health, by increasing your sleep drive, your need to sleep at night and be sleepy when you're supposed to be, and to consolidate your sleep so it's not as fragmented at nighttime. So regular exercise is great during the day. You want to be careful that it's not too close to your bedtime, because it can be actually alerting and activating, and it can decrease the body's core temperature to, ability to drop, actually. So keep in mind of the timing of your exercise. Circadian rhythm, okay? Our body works on a 24.3, like our circadian rhythm, and all of our digestive process, all of the different systems in our body have our natural biological circadian clock that just repeats over and over. You want your behavior to match with your biological circadian rhythm. So in blue here, this is sleep. These are the hours on the bottom. And this is our biological need to sleep increases as the day goes on. Our actual urge to sleep, the sensation, our feelings. So we wake up, we're supposed to be most awake during this time. Okay, most awake, and we get, and our urge to sleep suddenly increases again right here for everybody. There is an afternoon dip. The time we are most sleepy is in the early afternoon and when we're sleeping at night. Okay, this is a natural afternoon dip. Now, what's worrisome and not normal is if that dip is so pervasive and strong that you're having trouble staying awake, or it's affecting your functionality, etc., then we can talk more about that. But it is normal and healthy to feel more sleepier during that bump of time in the early afternoon. And of course, what you eat for lunch can obviously impact that. So routine is key. Routine. Okay, try to go to bed and wake up at the same time every day. But none of us, we're not robots. Sometimes we don't feel sleepy at exactly the same time each day. So what's more important is to we anchor the actual rise time, and we're a little more flexible with the bedtime. Okay. And just remember, even if you have trouble waking up in the morning, try to get up at the same time every day. Very important, including the weekends. Ultimately, that pattern of forcing that routine will help adjust your body's clock in a more permanent fashion, and it will help you feel sleepy when you need to feel sleepy. It's at the end of the day when it's time to go to sleep, and you want to feel awake and alert when it's time to wake up. Okay. A very common issue I see, because I interview all of my patients the first time on their sleep schedule, is social jet lag. So social jet lag is the bad habit of going to sleep later on, the weekend, and sleeping in later on the weekend, and then expecting to shift back on Monday, Tuesday, when you're more tired, wake up early again and shift your schedule between the weekdays and the weekends. If you think about it, that's like traveling between the East Coast and West Coast every week. No good, right? We've all experienced that and how that feels. And we just really don't want to shift our sleep schedules dramatically on the weekends and the weekdays. So routine is key. If you have trouble waking up in the morning, very important technique. And I do this especially with patients that have mild cognitive impairment or dementia, and their sleep schedule is all wacky and all over the place. So we have you wake up, and in the morning, within the first 20 minutes of getting out of bed, we need to get out in sun exposure into our retina, into our eyes for 30 to 45 minutes. If that is a walk, that's great. If that's sitting out on a balcony or sitting outside reading the newspaper, something where your eyes are not covered with sunglasses, a hat. And even if it's overcast, you'd be surprised the amount of sunlight that can get into your retina. So it's very important to feel awake during the morning and during the day and have cues for that, and feel sleepy at nighttime, not the opposite. That we see that a lot in dementia patients. Napping, there's a lot of controversy over napping. Okay, I mean, the long and the short is optimally, it is best to have our sleep all consolidated at nighttime over a long period, so we could go through those sleep cycles like I showed you and have those uninterrupted. The 4 to 5 non-REM, non-REM, REM, non-REM, REM cycles throughout the night, where we have more deep sleep and later more dream sleep. Okay, so that's not fragmenting sleep throughout the day. That's a long period at night. Now, in some individuals, a short nap may be refreshing and may not work too much against your nighttime consolidated sleep. What you want to be careful with about naps is sleep inertia, or how awake you are after your nap or after a sleep period largely depends on the sleep stage you're waking up from. That's why we talk about power naps. No more than 20, max 30 minutes, because if you're sleeping longer than that, you can get into your deeper stages of sleep. Waking up from a deeper stage of sleep is that feeling of feeling kind of drunk or out of it or confused, right? We don't want you, if you're taking a nap, to get into deep stages. We want the little light sleep, wake up and be refreshed by your sleep rather than more tired. That's what some of the apps try to do when they're looking at your sleep schedules. They're trying to time the different sleep stages you're at certain, based on your circadian rhythm. So it's waking you up out of a lighter stage of sleep and not out of a deep stage of sleep in the morning, so you feel more refreshed when you actually wake up. Okay. Let's talk about a sleep diary. So a sleep diary can be helpful in individuals. It can help identify habits and patterns that you can share with a sleep specialist like me and help you be more aware of your sleep. We're going to talk a little about it. There are apps, right, that can be helpful for this. But be cautious, because jotting down in a diary all your sleep or using an app, if you have insomnia, this can heighten or intensify your insomnia, right? Most people don't, that have a better sense of their sleep once they've figured it out. You don't need an app or you don't need a sleep diary constantly to better understand it. You have a pretty good sense. You don't need something telling you all the time exactly about it. Okay. We're going to talk about consumer sleep technologies a little later. So let's talk about actual sleep aids, which we call hypnotics. Okay. So there are two categories that I like to break them up into: FDA approved and off-label. Okay. So a lot of you may have heard about associations of sleep aids and dementia and increased morbidity and mortality. So let's just touch about that quickly. So kind of what happened in the history of sleep is, finally people, medical professionals realized, look, this is a really serious health impact if individuals are not getting enough sleep, people with insomnia or can't get sleep for other variety of reasons, right? So along came the birth of all these sleep aids, right? And through time, they morphed into what we call the Z drugs, because the generic names have Z in them. Zolpidem, which is Ambien. So like Ambien, Lunesta, Sonatas, which tend to work very well to help you sleep, right? So we have a ton of people prescribed these medications that are finally sleeping well, right? Well, then, unfortunately, all these big trials, epidemiology was looked at. What's happening to these patients? And we saw increased incidence in dementia. This is just one of the numerous papers. The increased morbidity and mortality, all cause in individuals taking sedating sleep aids chronically, right? So what I had showed you before about treatment really is that the first line of treatment should be cognitive behavioral therapy for insomnia, right? The medications really should not be what we're reaching to first, because medication should be an emergency Band-Aid. Again, understanding sleep aids are not fixing the crux of the issue. They're not addressing why you're having trouble with sleep. It's just a Band-Aid. So if you start it, there would be no end in sight if the cause of your sleep issues are not addressed, right? You don't just start taking a sleep aid with no end in sight and overhaul and change to your sleep or to figure out why are you having trouble with sleep. So really the sleep aid should be a Band-Aid as you're pursuing CBTI if you need a Band-Aid of sleep aid. And then later you have to go off of that Band-Aid. You have to taper off of that sleep aid, remember, which can be very hard the longer you're used to taking that. And those sleep aids, you can get habituated to them. There's all types of side effects. There's falls, there's cognitive issues, right? So you really want to be careful if you're having issues with sleep about starting that journey of starting a sleep aid, because remember, you're going to have to get off of it later and what that looks like, right? There's just this is just examples of different studies. There's just a lot out there about sleep aids and morbidity, mortality, dementia, all of that. So what are the FDA-approved sleep aids out there? Again, intended really for short-term usage. I like to break it down to 5 categories, okay? So the first category, which used to be a lot more common, are the traditional benzodiazepines. In red, I have the brand names, and black, I have the generic. So the brand names that you're familiar with of benzodiazepines, those are like Xanax, Valium, Klonopin, clonazepam, right? You've probably all heard of some of those medications. One of the most common ones for sleep used historically was Restoril, called clonazepam. Okay, that was pretty commonly used. Nowadays, some of the most common sleep aids used are the Z drugs, right? Zolpidem, Xalapon, Azopiclone, which is like Ambien, Sonata, Lunesta, right? Which basically just have different half-lives. Lunesta lasts the longest in the system, Sonata is the shortest, Ambien is midway, okay? Then the other category is melatonin receptor agonists. So the medication acts on the melatonin receptor, Ramelteon, also called Rosarum, but I don't want you to confuse it with Remeron, which is mirtazapine. A lot of people get confused because the names sound similar. Then I use this a lot, Doxepin, which is Silanor. It acts as an antihistamine. You know the word antihistamine I'm saying because Benadryl is an antihistamine. It has sedative qualities to it. And then the newest category that I want to focus a little on is the hypocretin, also called orexin receptor antagonists. They're called the DORAs. So this has a novel mechanism of action, this class, compared to all the others. So these other 4 classes act in a separate way. So I just want to understand, explain so you can understand how we sleep. Okay, so how you go to sleep is there are 2 centers in our brain. Your sleepiness centers have to be activated. You have to feel sleepy. Okay, that's part of going to sleep. And then our wakefulness centers, your mind that won't shut off, needs to be shut down. So traditionally, all these 4 classes of medications focus on activating your sleepiness centers, actually making you feel drowsy. Our patients are seeking often a feeling like they got hit with their head with a bat, right? They like and yearn that feeling, right? And that's what we have typically focused on. But over a decade ago, we had a different class that came along, these orexin receptor antagonists, and they don't make you feel sleepy per se or drowsy. They allow you to drift into sleep in a more natural manner because what they do is they shut down your wakefulness centers. And they came about because we had individuals that over age 65 or taking other medications with falls, and there's risks of dementia or cognitive issues or confusion. We just can't give these sedating potential medications, right? And so along came these. The brand names you may have heard of are Belsomra, Devigo, and Quviviq. And to date so far, we haven't seen, the big concerns about, it's still earlier, that we've had these drugs, but we're not seeing the same concerns as so far these sedative medications that can make you sleepy, lead to accidents, falls in the middle of the night, etc. Okay. This is just kind of a diagram. So orexin, which is the same name as hypocretin, activates our wakefulness centers. So Orexin, we discovered, is what is low in the cerebrospinal fluid of patients with narcolepsy, people that are too sleepy. That's what triggered. Understanding narcolepsy triggered these medications. Like, hey, let's inhibit these wakefulness centers and see how individuals feel. Again, a novel way of treating insomnia that's different from the other sedative forms. So I tend to use, if I have to use medications, I tend to often use these a good amount, and Silenor appear to be less habit forming physiologically. Then there's off-label medications. A lot of you may have heard of these. So you're basically using a medication for its side effect of sedation. And you usually don't want to use a medication for its side effect if there's other FDA-approved medications just to help you with sleep. So the common ones that are used are Remeron or Seroquel, olanzapine, gabapentin, trazodone, right? There's a lack of evidence of these being effective, which is why they are not FDA-approved sleep aids. And I really steer away from these unless you have a primary disease or indication for taking these medications, because then they could potentially also help you with sleep. So a common example is someone with diabetic neuropathy or a pinched nerve or something that takes gabapentin, and maybe we can augment the gabapentin, increase the amount to help them temporarily with sleep. Okay, but I don't tend to reach to those first. Other options, if you have a wait list to get into CBTI, you're hesitant about it, etc. What other options do we have for psychophysiological insomnia? And that is these online CBTI programs and different books you can look at. Oh, I got to keep my eye on the time. So let me, so the future, let's just talk about consumer sleep technologies quickly. So those are in the categories of nearables, wearables, or apps. They all use different type of technology to measure different things like temperature, humidity, microphones, heart rate, optical heart rate. This is very important. The American Academy of Sleep Medicine has a position statement that was released in 2018, because these are exploding on the scene and we need to know what we do about these and what we think about these. So it's important for everyone to know that consumer sleep technologies are not validated versus gold standard, which is polysomnograms in the lab where we look at your brain waves. And they're not FDA cleared. Please understand, none of these are FDA cleared. They go into the category of lifestyle entertainment devices, okay? They don't use empirical evidence or national guidelines. They cannot accurately identify sleep disorders. The raw data collection and algorithms are not standardized or disclosed to us or validated. And it's largely proven to accurately measure sleep. And I'll talk about an example study. And there's possible, the worst part of it, there's possible data misrepresentation or interpretation. So with a grain of salt. So let's talk about this. So what do I have? So this has just hit the scene and the sleep specialists are being inundated with all of this. I have access to a website, for example, where I can just type in something. I chose the Whoop. I know here in the Boston area, a lot of patients will use the Whoop. So I just type it in here and it pops up with some just general information. And when I click on this, it'll show me a ton of academic papers, let's say, that have to do with it. So I can give you an example of just one I looked up for the purpose of this talk. So a validation study of Whoop, the strap against in-lab studies. Okay, so what did it show? So the Whoop is just so some of you know, that wearable device, and it tries to estimate sleep based on movement. That technology is called actigraphy. And it looks at heart rate via photoplethysmography. PPG is the technology. Quickly, side note, PPG, which is used in most of these wearables, nearables to extract data. This is a picture of a finger, right, in a pulse ox. It's using PPG. So it's an optical technique that's used to detect blood volume changes in the microvascular bed of tissue. So in these vessels right here. So it's measured at the skin surface, right, just like a pulse oximeter, and it can provide you some valuable information about the cardiovascular system. So that PPT technology is really being used in most of these wearable devices. So what did this study happen to show? The Whoop versus an in-lab study. They looked at, this is a small study, 6 males and 6 females, aged 22.9 plus or minus 3.4 years. They looked at 10-day sleep laboratory protocols, and they showed the sensitivity to pick up sleep was 95%. That's great. The sensitivity to pick up wake, like how much you're awake after falling asleep, 51%. Not so wonderful. Light sleep, 62%. slow wave deep sleep 68%, and dream sleep 70%. Okay, I've looked up a lot of these studies, like the Fitbit, the Oura Ring, all that. What I would say is the big picture, the long and the short of these devices is they're pretty good at understanding sleep, like total sleep time, right? Albeit, these devices were studied in healthy individuals, so individuals without sleep disorders, okay? Where a lot of individuals with sleep disorders are trying to look at this data and understand it. So the technology is developed in healthy individuals, okay? However, the time after falling asleep that you're awake does not tend to be very accurate, and it's less accurate the more time you're awake after a sleep. And we don't have very good accuracy for the sleep stages. I also took a deeper dive than most people would look and see how, for example, the Oura Ring defined deep sleep. In deep sleep, they put N2, which is light sleep, into their deep sleep calculations, right? So you really don't necessarily know what these devices are measuring, right, necessarily in everything that it's giving you. Now, I like to hear the data that patients get. I'm interested in hearing it. I actually promote my patients, hey, if you're going to do a sleep study, even at home or in the lab, wear your device. And then I'll show you our data, gold standard being in lab, and we can compare it. And it has been pretty similar to this, actually, the sleep staging and all of that. So, I find it helpful for the consumer sleep technologies if an individual really knows nothing about their sleep, or they just kind of want to get a better gestalt. But we're really not there yet, I'd say, for the accuracy of all of this, right? And then just really quick on, and you guys can cut me off whenever just about cannabis and sleep, because so many individuals come into me, I talk about what you've taken, and a lot of people take medical cannabis, THC, CBD. So what's the information on that? Let's first talk about these different terms, because a lot of people don't even know what they're taking, actually. So cannabis contains over 400 compounds. THC is the major component of cannabis. That's what causes that high. Okay, that's THC. CBD, which you can just order online right now, right? You can go in a store. It's the major non-psychotropic component of cannabis. So there's no high. Okay. And then you may have heard of hemp. What's hemp, right? Industrialized hemp is a plant of the genus cannabis, and any part of that plant, whether growing or not, containing a THC concentration of no more than 0.3% on a dry weight basis, okay? The composition of cannabinoids within medical cannabis, the issue is it varies significantly and it's not regulated. You get your license, you go into a dispensary, and there's a person there that interviews you and asks questions, and I've interviewed on this and talked to centers. It's not standardized. They don't have standardized protocols. They just kind of hear your symptoms and decide, well, let me increase this dose. Let me change your ratio, THC to CBD. It's just not yet formalized enough yet. And synthetic medical cannabis maybe have different effects, et cetera. So there's just a couple more slides of this. So the cannabinoids in sleep, let's just look at a quick review from 2017. What are some of the major findings? THC can decrease the amount of time it takes to fall asleep, but it can impair sleep quality in the long term. Of course, we all know it can impair your memory as well. CBD may have therapeutic effects for insomnia. Overall, the findings on cannabis and sleep show that long-term use can have a negative impact on sleep. Chronic THC results in the development of tolerance to its effect on sleep. Habituating cannabis can lead to using more cannabis to get that effect again. And sleep disturbances are a hallmark of people withdrawing or stopping or trying to decrease cannabis, and can lead to relapses in usage of this. Low CBD has stimulating effects, can wake you up more actually, and then the higher dose ones, like 160 milligrams, can have a sedative effect with increased total sleep time and decreased number of awakenings throughout the night. But the other paper I looked at, the acute effects of CBD, just CBD specifically, the non-psychotropic, right, that all of us can just get if we want it online right now. It looks at the effects of CBD on an in-lab study. What did it do to people's brain waves when we looked at it? So an amount of 300 milligrams administered 30 minutes before sleep, that's what was looked at. And the findings was that the CBD did not affect the sleep-wake cycle of the healthy volunteers. And CBD does not alter normal sleep architecture. So that was just this study. There is now, in the epilepsy world, for people with certain epilepsy syndromes, the first FDA-approved CBD. It's called Epidiolex, right? This is a 100 milligram solution. What will be interesting is what I'm trying to lead you guys to all understand is there needs further research, and that will be happening. And then these are just a list of quick symptoms. I just have 2 slides. When you would need to know to come for a sleep consultation, right? So a lot of these are going to be symptoms of sleep apnea, and some of them not as obvious. Of course, snoring. If someone hears you or you stop breathing, you gasp or choke at sleep at night. If you're moving excessively or someone tells you about that, your arms, your legs flailing around. If your sleep is unrefreshing. I also specialize in people that are excessively sleepy, hypersomnia, just low energy in general. If you have frequent urination at nighttime, it's not necessarily your prostate or your liquid. Sleep apnea actually causes a sympathetic surge and to need to urinate. Frequent napping or dozing, mouth breathing is a sign that you're having trouble breathing through your nasal passage. Grinding or clenching your teeth is a common manifestation of sleep apnea. Night sweats, sympathetic surge. Sleep talking, sleepwalking, physically acting out your dreams at night, although it sounds funny, can be a sign of something much more dangerous. Restless leg syndrome, like discomfort in your legs. When you get in bed or sit for too long, you need to massage them, walk around. Waking up with headaches in the middle of the night or in the morning. Sleep paralysis, where you're paralyzed when you're transitioning in or out of sleep despite trying to move. Having sleep attacks or having concentration complaints. Also, there are individuals that have sleep apnea, please understand, that have 0 symptoms. The group here is probably very familiar with that people say they don't snore, they're not sleepy, etc. But we end up doing sleep studies on those individuals very often because they have some of these diseases that sleep apnea causes. And we pick up sleep apnea in these patients all the time. So what you have to remember is sleep apnea can be a silent killer. You can be asymptomatic. It can be like high cholesterol. You wouldn't feel it, but we check it in your blood and we find out you have it. So it's really important to remember for individuals. This is just pictures of sleep studies. And I can end there. These are take-home points because I know we're over. Sorry.
Not at all. That was great. Thank you, Karen. Really well done. And I can tell by the number of questions also that we've had typed in that the audience was really excited to learn about this topic. And what we'll do is we will ask Dr. Lee to answer the individual questions that we didn't have time to get to today. And then we'll circulate that to everybody. And this certainly seems like a topic that we might need to have you back, Karen, for part 2, because I think so many great pearls here, and I think the audience really wants to dig in. So, so this was really wonderful. I also just want to put a plug in for our patients that we have another webinar planned for October, on October 16th. Dr. Marie Gerhard we'll be talking about peripheral arterial disease. And then we have a November lecture on the 6th about breath work with Dr. Armand. So we look forward to seeing everyone back. And Karen, thank you again for being so generous with your time and for all the great information. All right, we'll see everybody again soon.
Take care. Thank you.